Hey guys, it's Erica, Sharina, and Ryan here. We're going to be talking to you about the importance of lower patient-nurse ratios. We're going to identify and explain interventions to solve this issue, and we're going to also identify factors that increase this issue and also how are nurse practitioners affected.
Description of the issue of high nurse patient ratio. It can be critical to patient care and outcomes. Nurses, their careful observation at the bedside is crucial to their ability to ensure patient safety. In emergent situations or departments, in emergency department, the nurse ratio is 1:4. In acute ICU settings, I think the nurse patient ratio is 2:1. However, increasing the number of patients assigned to one nurse eventually will compromise the nurse's ability to provide safe care. From a safety perspective, nurses are counted on to detect errors, near misses, monitor patients for clinical deterioration, and also understand the care process and communicate identified change in patient conditions. Factors that influence this issue is inadequate nursing staff, high acuity level patients, high admission rates, availability of technology and resources, and education and training. Leaders have a great impact on high nurse-patient ratio issues. Leaders who accept personal accountability and operate as a transformational leader will encourage their staff to use their critical thinking styles, will also motivate their nursing staff by taking overflow assignments to assist in this nurse-patient ratio issue. In return, they will create a positive work environment and promote better patient outcomes and safety. Leaders who hold themselves accountable for maintaining patient safety will have a positive impact on high nurse-patient ratios. Teamwork and communication effect on the issue. Lack of communication and teamwork among nursing and assistant staff can result in harm to the patient. This can cause medical errors, poor healthcare outcomes. Communication and teamwork skills are important for providing quality patient care. When clinical and non-clinical staff come together and collaborate effectively, healthcare teams can improve patient outcomes, prevent medical errors, improve efficiency, and increase patient satisfaction.
Adaptive informatics on nurse-to-patient ratio. A study done by Qureshi examined geographical bed assignment and workload of a nurse through a computer application. The researchers found that nurses walk 7.3 miles, which would take an average walker 2 hours. This application allowed for charge nurses to examine the best placement of nurses. If an individual is walking this much, then it would be best to use this time appropriately, such as charting on a patient with a voice recorder that transfers to their chart. Campos conducted a 90-hour observational study in Brazil. 16 nurses found that nurses spent 44% of their time communicating, 24.2% of the time walking, and 15.8% of the time documenting. California is the only state to require mandated nurse-to-patient ratio laws, according to Davidson. By not requiring mandated overtime, this makes the profession more appealing to individuals to have a career that provides a balance in work, life, and creates opportunities for individuals to return to school. Nurses who have a certain amount of experience without an advanced degree should be allowed to be nursing school faculty members. This would benefit the 47,000 to 68,000 applicants turned away annually due to lack of faculty resources, according to Costa and Fries. Registered nurses make up 60% of employment in hospitals. LPNs make up 15% of employment in hospitals, according to the United States Department of Labor. The benefit of bringing LPNs back into the hospital setting would allow for more tasks to get done through delegation of an RN to an LPN. The change theory that I chose was ADKAR change management model. Wong described the use of ADKAR change management model in order to open a new hospital with an evidence-based model called acuity adaptable care. This prevents moving patients throughout a hospital, instead having the same staff throughout their whole stay to help prevent medication errors. They also found it helped prevent errors in handoff reports, also diminished falls and mortality by having consistency in your care with nurses that are with you throughout your stay. Awareness for the ADKAR change management model consists of being aware of the number of nurses that are leaving the profession due to burnout from being understaffed. The desire for the change must come from within the federal government to pass bills such as the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act of 2021. This bill was not enacted into the law. Knowledge would have to be shared with nurses on utilizing the technologies that will be introduced into the facility. Ability. Once individuals get used to the technology or working with an LPN, then there should be weekly updates on issues with the change in order to maintain efficiency. Reinforcement will have to be utilized by ensuring that nurses make use of their resources and to ensure that they do not resort back to the unmodernized ways of patient care.
Hey, my name is Erica, and I'm going to be discussing how each intervention is ethically positive or negative and the ethical considerations. The first intervention was to create a law minimizing the patients a nurse can care for. This is ethically positive because it allows a nurse to care for each of her patients in a more thorough way, without the hardship of being overwhelmed. The next intervention suggested was to not allow employers to mandate overtime. This is ethically positive because it reduces nursing strain and nursing burnout. However, we should also think about nurses who pick up overtime volunteering. Should they be allowed to pick up overtime when it is over-consuming them and their nursing care? This is an ethical decision we must make. The next suggestion was to cut back educational requirements for nurses to become educational leaders. However, this is ethically challenged because if we cut back the education, will they be able to teach rising nurses all they need to care for the patients in the very best manner? And the last intervention discussed was to hire more LPNs. However, this can be ethically challenged because the LPNs cannot push drugs and cannot do some skills a nurse can. Therefore, this puts us at an issue of slowing down RNs to care for the LPN's patients. Hey, it's me, Erica. I'm going to be talking about how each intervention requires a policy change or either a new policy. Intervention 1 was to create a law minimizing how many patients a nurse can handle on their own. This will require a new policy stating a certain number of patients per each nurse. There may need to be a secondary policy stating if RNs can take a larger caseload than LPNs. This will just have to be considered in the thought process. Intervention 2 was no mandated overtime. This needs a new policy creating no mandatory overtime. A consideration we need to think about is, will there need to be a policy in place for nurses that like overtime? Will we need to inhibit how much overtime they can handle? Third intervention was educational teaching and cutting back the mandation of advanced education. This needs to be a new policy. The fourth intervention was to increase LPN scope of practice. To this, a whole new policy needs to be created of what they can and cannot do. Hey, it's me, Erica. I'm going to talk about the role of the nurse practitioner in this issue of high nurse-patient ratios. The nurse practitioner is responsible for ordering orders for the nurses, and they need to make sure the nurses implement these orders. When nurses are short-staffed and have high patient loads, they are unable to complete the APN's order in a timely, ideal fashion. This affects patients' satisfactory scores and patients' attitudes towards all staff. In consequences, this can cause the nurse practitioner to get bad reviews. Also, a decrease in staff increases the patient length of stay, due to one nurse having more orders to complete with no help. Increased level of stay can affect the nurse's turnaround time, and this also affects their pay level.